My name is Bill Soros. I'm the Director of Harm Reduction Services for the Department of Emergency Medicine at Bay State Medical Center. And I'm an Assistant Professor of Emergency Medicine at the University of Massachusetts Medical Center, the Bay State campus. I am lucky enough to give the first presentation. And the title of this first talk is Substance Use Disorder is a Medical Disease. And, this is deliberate, this title. It's not viewing substance use disorder as a medical disease. It's not substance use disorder is kind of like a medical disease. No, it is a medical disease. And this is going to be an incredibly important point because it really provides the foundation for the rest of the conference. Understand that the single largest barrier in the treatment of substance use disorder is that we, as healthcare professionals, falsely attribute behaviors to the quality of the person rather than to the severity of their disease. Let's take an example. Let's take a 58-year-old female who has congestive heart failure. She comes into my emergency department. She is short of breath. She is gasping. I put her on positive pressure. Right? When I look at this person, right, I look at her shortness of breath and I say, this is part of her disease process. And as a medical provider, I'm going to treat and try to improve that disease process. I do not think her shortness of breath is part of her being a person. I don't think she lives with this all the time. I recognize this as a manifestation of her disease. This is true for all other diseases that we think about. But for some reason, especially for substance use, we don't. We attribute people's behaviors, we attribute people's actions as that's part of who they are as a person. They are a bad person. What we don't interpret is, no, this is their disease and they're really suffering from this disease. And that's important to understand because the disease of substance use disorder really hijacks and alters the brain. And when people present, maybe they are angry, frustrated, withdrawing, anxious, maybe they have behaviors you wouldn't normally think of, that is not reflective of the person, that is reflective of their disease. And I'm going to spend some time really talking about this because it is such an important point. Let's start by defining what a disease is. A disease is factors such as genetic or developmental, infection, poisons, or environmental that cause disordered or incorrectly functioning organs, structure, or systems of the body. Take something all of us think of as a disease, cancer. There are genetic or developmental errors. There can be poisons or toxicity involved. There can be environmental factors, all of which contribute and may lead to a disordered functioning system in the body. The same definition let's use and explore for substance use disorder. There are genetic predispositions. Right? We know that families that have substance use disorder, those relatives are more likely to have it. Parents or other relatives that have substance use disorder, children are more likely to have it independent of that environment. Obviously, poisons or toxicity play into substance use disorder. And you may be tempted to kind of prescribe that fault to the person, but I'd say a few things. We don't do that for any other disease. You don't look at the lung cancer person and say, this is your fault, because when you were a kid, you started smoking. We don't say that to the diabetic. We understand that, sure, there may be some choice in the beginning, but this is a disease. The other important thing to think about with substance use disorder that is really humbling is that this was a disease that we as healthcare providers were partially responsible for. Our overprescribing of opioid medications was one of the factors that led to the opioid epidemic. In fact, initially 75% of heroin users, when the opioid epidemic started, say that they began their opioid use disorder with a prescription medication. Right? And so as much as you want to assign blame, realize a lot of that blame lies on us. And then obviously there are unfavorable environmental factors. How and where someone grows up, especially as a child, can really influence. And it's hard to find fault in that. Right? Things like child or sexual abuse plays a large cause and contributor into substance use disorder. Homelessness, other drug use around them, all plays in, right? And that is not a fault, that is a part of the disease. And then the last part, And I think this is the part which people maybe don't have a grasp quite on, is that it causes some disordered or incorrectly functioning system. And I'm going to show you exactly how substance use disorder causes dysfunction in the body. We have to go back to the reward system. So the brain has a natural reward system, and this has been developed since the development of people. Right? The reward system was initially developed and used to reinforce positive behaviors, things that were good for the person. So thinking about foods that happen to taste good, right? Eating something and saying, this tastes good, this is probably good for me, would spike dopamine in the brain reward system and would create a reward feedback loop. So the next time you saw that, you would want that food, right? And that helped maintain survival. Sex, another thing, right? Helps maintain survival. These are primitive baseline functions. What happens? Well, with any addictive substance, a part of the addiction is that it hijacks this reward system. So you can see a normal reward dopamine level in this graph lies around 100 and goes probably from about 50 to about 200 normally. Addictive substances hijack and multiply the dopamine level many-fold to the point where it is super therapeutic. It is too much. The brain does not know how to handle that much dopamine in the reward system. Let's take a look at it as a graph. So the yellow is a normal level of dopamine in the reward system. The green is too high, and the red is subtherapeutic or too low. We're going to look at the x-axis, which is over time or could be over uses. You can see initially when someone uses the first time, that dopamine spikes really high, too high, where the brain has trouble understanding. And in fact, when you talk to people, it is difficult for them to describe what that first time was like. Again, because the brain just is not used to that level of dopamine. It is too high. So people make outlandish statements. It was like being hugged by God the first time that I injected heroin. But what happens? As medical providers, we know that when the body senses something is off or subtherapeutic, it's going to try to correct it. And so almost immediately after, when the brain sees this supratherapeutic dose, it downregulates receptors. It says, that was too much. I need to make less, because that can't happen again. And so you can see even the next time they use, it spikes high, but it doesn't spike as high. And that's important because people will tell you, I've never had a high like the first time that I used. And that is actually physiologically true. But you see what rapidly happens is as the brain keeps spiking, the brain keeps downregulating to the point where it tries to get back to normal. But what happens, if the person continues to use, then all of a sudden, normal becomes subtherapeutic. When they are not using, they are not producing enough brain dopamine. And in fact, the only way they can get back up is to use. The only way they can get back to normal is to use. This is an Fmri. On the left side of the screen, this is a healthy control. And on the right side, this is someone who actually, I believe, used methamphetamine. You can see decreased color saturation in areas that are black. This is decreased uptake. This is downregulation or destruction that you are actually seeing in the reward system of a person with substance use disorder. This is the definition of the disease that you are looking at right now. You can physically see it as a structural difference in the brain, the downregulation or destruction of these receptors. People comment in the beginning, it feels really good. You're paying to get high. And towards the end, you're feeling really stupid because you're paying not to be sick. And what happens? People try to stop, right? Go to the end of the line, but they stay. The downregulation lasts for a long time, and some people may be permanent. And so they stay in that subtherapeutic level. They stay feeling awful. Everything hurts. It hurts to comb your hair. It hurts to shave. You have no energy. You feel weak. You feel a sense of desperation. You have constant impending doom and anxiety because you realize that with one pack of dope, you can change how you feel. You can feel normal within a matter of seconds. Now come back to the person. Can you see that those behaviors, especially when someone is withdrawing or feeling awful and feeling frustrated, those behaviors are part of that disease, that the brain reward system has been dysregulated and dysfunctional, and the only way that they know how to get it back to feeling normal is to try to use again. And all of a sudden, all of those behaviors that you once said, that was a person and that person is bad, no, it's not. It is a manifestation of how severe their disease is. Substance use disorder is a chronic medical disease. And just like any other chronic medical disease, it's not a choice. Just like any other chronic medical disease, it is worthy of treatment. It is understanding that non-compliance or relapse is part of a chronic disease process. And that finally, depending on the type of disease, and the person's success may be defined differently. And it may be defined differently than what the physician or what the provider thinks of as success. As a disease, we have treatments, and we have treatments that work. There are 3 licensed treatments for substance use disorder, for opioid use disorder. Naloxone, which actually we're not going to talk about too much. Naloxone is an antagonist and blocks all effects. It has uses, and it has been proven in some patients, but there are lots of drawbacks, and we won't get into it as much. The other 2 are methadone, which is a full agonist, much like any other opioid we use, whether it's morphine or Dilaudid or prescription opioids, it's a full agonist. It's long acting rather than some that are short acting. And then buprenorphine, which is a little bit different, and something we're going to touch on more, which is actually a partial agonist. If we take methadone and buprenorphine, the idea of these 2 medications is to take someone who is on this roller coaster and get them to here, where we are not getting them high, but what we are doing is we are giving them long-acting opioid replacement therapy to get their brain levels to a place that is as back to normal as we can be. We are putting them back to a starting point so that they can continue to get better from their disease. Now, we'll touch on methadone a bit more, but I think buprenorphine is the one to touch on because its method of action is a little bit different, and you will see it more. First, to note some definitions. So the buprenorphine-only formulation is called Subutex. Buprenorphine plus naloxone is known as Suboxone, and this is the most important part because this is what we'll see the most. The naloxone portion, if the Suboxone is taken as it should be, which is dissolved under the tongue, the naloxone does nothing. It is inert. The naloxone was only put there to try to act as a deterrent if patients attempt to inject, which is not how Suboxone is supposed to be used. So if patients are using Suboxone the way it is prescribed and the way it's meant to be taken, it is no different than using the buprenorphine-only formulation. There are other formulations. There's an extended release injectable known as Sublocade. There's also IV buprenorphine, which may be in the hospital, and a transdermal patch, which is licensed for pain only, and we won't describe too much more here. Understand 2 important things about buprenorphine. First, it is a partial agonist. It will activate receptors, but even when it saturates, it's only going to activate those receptors at 50%. And the second is that it has a really high affinity. Once it sticks to those receptors, it's actually going to displace other opioids and stay on that receptor. This causes 2 practical things. First, it is virtually impossible for a patient with opioid use disorder and tolerance to opioids to overdose on buprenorphine alone because it does have that 50% activation where it maxes its ceilings. The second is that buprenorphine can actually have a protective effect in that the affinity for that buprenorphine on that receptor is actually higher than many other things like heroin. So someone on buprenorphine, and again, not fully protected, but maybe somewhat partially protected, especially in things like an incidental relapse. Does it work? This is a study looking at an index opioid overdose, and they followed them out 12 months to look at mortality. What they found is in this relatively healthy group of 20 to about 50-year-old people, the mortality after someone has an overdose, the 1-year mortality is 5%. And that is incredibly high. There are not many other diseases that we know of that has a 5% mortality in this age group. If they then looked at folks after their index overdose and they were put on treatment, specifically if you look at the triangle, which was morphine, or the square, which is buprenorphine, it cut that mortality in half. Let's put it in a number way. We think about the effectiveness of medications as NNT, or number needed to treat, meaning the number of people I need to give this medication to prevent something. Our strongest thing to prevent is death. Let's look at the numbers. Some of the most important things that we do: lung protective ventilation for ARDS, a number needed to treat of 10 to 14, meaning you need to put 10 or 14 people on this ventilation strategy to prevent a death. Antibiotics and GI bleed, 1 in 22. Buprenorphine, 1 in 30. Now that may not seem impressive, but think about other things. Think about Coumadin for AFib. Think about aspirin for secondary heart attack prevention. 1 in 333 people. You have to start 333 people on aspirin in order to prevent 1 death. And yet aspirin we use all of the time. Buprenorphine, 1 in 30 to prevent death. Now, one of the things you have to understand, and this is why I talk a bit more about buprenorphine, is this idea of precipitated withdrawal. It is a very safe medication and it is a very effective. But the issue is that if buprenorphine is taken too soon after the last use of a full agonist like heroin, it actually takes that heroin, it displaces it off, and it attaches to the receptor, and it will drop that receptor activity, right? If someone was on heroin and the receptors are at 80%, the buprenorphine will take it off and it will down activate to 50%. What will the patient experience? Well, going from 80 to 50%, they're going to start to feel bad and they'll feel symptoms of withdrawal. Therefore, buprenorphine works the best if it's been time since the last use of a short-acting opioid, usually 8 to 12 hours, we like 24 hours sometimes, and the patient is already experiencing some withdrawal symptoms. Because if they're experiencing withdrawal, then the receptors are probably pretty low and that buprenorphine is going to work for them. So just be aware of this effect, and that's the thing that we want to make providers aware of when thinking about buprenorphine. To come back to it, understand this is not a comprehensive course in buprenorphine or methadone. We will have more to talk about with these, but also remember we have a variety of clinicians here, some of whom are prescribers, but some of whom are not. So we want to make people familiar with these medications. We will have resources at the end with specific algorithms, treatment algorithms if you are a prescriber. The big thing to take from this lecture: substance use disorder is a chronic medical disease. This will be repeated throughout our conference. And it's not just understanding that, but it's understanding what comes with it, that it's not a choice, that these behaviors that you are seeing in people are part of their disease. And that disease can be treated. That's the important thing, that you, by initiating treatments and initiating harm reduction, can help that person. As a disease, it is worthy of treatment. And medication should be offered, really without conditions. We don't put conditions on starting someone on insulin for diabetes. We don't put conditions on starting chemotherapy for lung cancer, right? We don't say, hey, I know you've smoked all your life and you have this lung cancer. I'm not going to start your treatment until you stop smoking. That is just not humane and not what we do as providers. We should not do it for substance use disorder. Understand, as a chronic medical disease, noncompliance and relapse are part of the disease process, but also it shouldn't threaten access to medication. Meaning that if you are a diabetic and you eat poorly for a week, I'm not going to take away your insulin. I may talk, we may come up with plans of how to do better, but I'm not going to threaten your medication because of a relapse. And then also understand that success sometimes is defined differently, and medication should support what the patient thinks of as success, not what the provider thinks of.